This is the Psychcast by MDedge, where we bring you interviews with leaders in the fields of psychiatry and psychology, masterclass lectures, and relevant inspiration, with new episodes dropping on Wednesdays. I'm the voice of MDedge Podcasts, Nick Andrews. And welcome to episode 110 of the Psychcast by MDedge. I am Nick Andrews. At MDedge, we're utilizing our full editorial engine to bring you the most up-to-date information on the novel SARS-2 coronavirus and, of course, COVID-19. We understand that the mental health fallout will be tremendous and mental health care professionals will be instrumental in this process. Therefore, we aim to present as many episodes as we can that will be relevant during and after the pandemic. Today's topic, could it be more prevalent? Loneliness among the elderly. In the interview portion of the episode, MDedge Psychiatry Editor-in-Chief Dr. Lorenzo Norris welcomes Dr. Steven P. Wengel of the University of Nebraska College of Medicine to discuss exactly that. And later, Dr. Renee Kohanski is here to talk about being anti-fragile as an individual, nation, and as a people. You can find the Dr. RK segment, as always, following the interview. Before we get to the conversation, we'd like to mention and request that if you have any idea for topics or guests for the Psychcast, specifically as they relate to COVID-19, please email us at podcast@mdedge.com. You can find our email address in the show notes. And speaking of show notes, our notes this week are authored by Dr. Jacqueline Posada. They include links to material referenced in the conversation, as well as an outline of topics and biographical information for Drs. Norris and Wengel. And now, without any further delay, please welcome the host of the Psychcast and the Editor-in-Chief of MDedge Psychiatry, Dr. Lorenzo Norris.
This is Dr. Lorenzo Norris, Editor-in-Chief of MDedge Psychiatry. It is my pleasure today to welcome Dr. Wengel on today's Psychcast. I'm really looking forward to speaking with Dr. Wengel today because it's going to be on a topic that is really affecting everyone across the country. The topic is going to be on loneliness, and in particular, loneliness in the geriatric population. And we're going to really try to work and think about what are some of the consequences of loneliness, what are the different ways that we can think about it, and we're going to be upfront. We're not necessarily going to have answers, but what we are going to do is ask some tough questions and see where the conversation takes us. So please do stay with us on this really, really important Psychcast, and it's going to be great talking with Dr. Wengel. So, Dr. Wengel, welcome to the Psychcast.
Thanks for having me. This is a really important topic, and I think very timely.
Yes, Dr. Wengel, I would agree with you completely. Obviously, anybody has to do is turn on the news, and you're going to be flooded, inappropriately so, with information regarding COVID-19. You'll hear Dr. Fauci talking. You'll hear many of our colleagues across the country speaking about the public health consequences of COVID-19. And what you will really start to also see is that people are really talking about the mental health consequences of COVID-19, given the different behavioral things that we've been asked to do, particularly social distancing, quarantining. All of these things are having significant effects on every segment of our population. Dr. Wengel, could you please tell us a bit about, in terms of your role as a geriatric psychiatrist, how you view the consequences of potential loneliness in the geriatric population who may be dealing with definitively dealing with the ramifications of COVID-19?
Yes. There's been some really, really interesting research coming out of, I think, mostly sociology and psychology over the years, looking at loneliness as a predictor of health problems, for example. And we've known long before COVID-19 was a thing that older adults often suffer from loneliness. Not just older adults, of course. I mean, there's some people refer to an epidemic of loneliness in the U.S. And, there's a lot of things we could say about that we are the most connected and yet disconnected society we've ever been, and so forth, with, a lot of virtual things, social media versus live connections between human beings and all that. But, looking at the older population in general, because of frailty, because of transportation problems, because of, you name it, older adults often are socially isolated, pandemic or not. And some really, some interesting and I would say sobering research has shown that, first of all, it's extremely common, that loneliness is extremely common in older adults, and it has some startlingly serious health consequences. For example, a study I looked at recently showed if you look at older adults in nursing homes, again, this is pre-COVID-19, 9%, almost 10% of them will say they are often or always lonely. So almost 1 out of 10. 1 out of 4 will say at least sometimes. So it's really, really common. But let's look at some of those consequences you mentioned. It's actually an independent risk factor for mortality. People can actually literally die of loneliness. It also is a predictor of other things like high blood pressure, overall sort of poor physical health. And then again, in my field of psychiatry, depression, certainly, loneliness and depression seem to go together, and it works both ways. Depressed people will isolate themselves from others, and that makes the depression worse. But even if they're not depressed, somebody that starts out lonely often then becomes depressed. And then an area of literature which I think is kind of still evolving is looking at loneliness as maybe even a risk factor for dementia. So it again, I think it's still an area in evolution, but an area that looks like there's a pretty strong signal that loneliness is more than just sadness or more than just a state of mind. It is, I mean, it's bad enough that it is that, but it is something that clearly seems to be having some major health consequences.
Well, absolutely, and I'm glad. I want to make sure we got that for the listeners because this is vitally important in terms of some of the evidence that is out there. We have here loneliness being seen as an independent risk factor in terms of mortality. We've known that it's a predictor in regards to, or it influences certainly high blood pressure. I would agree with you completely, and I would dare say this is something that doesn't really need to be overly articulated, that loneliness and depression do go together, and I would imagine that any of our colleagues in mental health or medicine or sociology or social work for that matter would absolutely agree with that. And then also an interesting finding in regards to loneliness as a risk factor for dementia. First off, did I get all of those? Dr. Wengel, did we hit those 4 main points?
Yes,
exactly okay.
Right. Thank you.
All right, excellent. Now, one of the things when you're speaking about this in terms of loneliness, it's more than just, if you will, an emotion or a state. Or what I do think about is how our brains and our minds are constructed and how we process information, and it was constructed to do so in a social context. So loneliness, again, I am not a neuroscientist or anything of that nature, but it's clear that loneliness has significant effects on our health, and it's a field that people are studying. So we've talked a bit about the consequences of loneliness, or what some of the consequences are, but there's loneliness and then there's being alone. I know there can be times in my life where I'm perfectly comfortable being alone. And for me, that is quite different than being lonely. Can you elaborate a little bit for us, Dr. Wengel, in terms of that important difference, in terms of the difference between being lonely versus being alone?
Right. And you said it well. They sound the same at first blush. At a superficial level, it sounds like, well, gosh, that's being alone, being lonely, and they often go together, but they don't necessarily. And you said it again well, and I appreciate your candor about yourself. And I would say the same thing. There are times in my life when being alone actually feels pretty good. It's a choice, and sometimes I think we all need that. They're even saying, like with quarantining now, with families all being together, that we all need a little bit of alone time. So it's okay to take that book into your bedroom and read by yourself for a little while, for example. So being alone doesn't mean you're lonely necessarily. And likewise, you can actually be lonely even when you're in a crowd of people. As a side note, but I think it kind of bears on this. So I mentioned I'm doing a lot of wellness work for my institution. we're looking at loneliness in physicians, for example, as one of the risk factors for physician burnout. Well, physicians, are not alone typically. They work with nurses and obviously patients all day long, and yet they are often, when you ask them, they'll express loneliness because they are not able to spend quality time with their families, often because they're so busy with their work, but also even on the job, they don't really have time to interact with one another. So I think, again, that's a little bit off the topic, but I think it still kind of bears on this notion that you can be with other people all day and still be lonely.
Well, I think it's vitally important. I want to stay on this in terms of you can be with other people and still be lonely. When you say this is what I think about. I think about choice and authentic connection. All right. I can be alone. All right. But if I feel as though I have a choice in terms of accessing people, then I think that I'm fine. And I'll do maybe a little bit of disclosure for the audience. I grew up single-family household. It was just me and my mom, and I spent a great deal of time alone. But I always knew that I could always access my mom or other family members. So I did not. For me, I think about choice. I did not feel lonely. The next thing I would add is authentic interaction. All right. When I choose to connect, I can actually have a meaningful interaction, and that's going to differ for different folks. And I would actually challenge people. I don't necessarily think it has to be as long. I don't think there's necessarily a duration on it. I think it's whether it is meaningful and whether or not we like to say, did you feel heard and did you feel listened to, or and conversely. So when you talk about the difference between being alone and lonely, I haven't done the research on loneliness or anything of that nature, but I'm just going off of kind of my own gestalt and also what my patients share with me. But I go back to choice and whether or not you're actually having an authentic interaction, and what that authentic interaction is different for different people. And I think going back to what you said in terms of our geriatric patients, that's gonna differ. But I think about those two things. So I put that back for you. Get your thoughts.
I completely agree. I think you've hit the nail on the head on both counts. So choice, or autonomy, for example, would be the other way to spin that concept.
Yes.
That we like being as much as we can be, or fate allows us to be the captains of our ship. We like making choices for ourselves, and when you choose to say, do you have some alone time, that's a great thing. It feels good. But you're right, when it's when it's thrust upon you, like right now with COVID-19, because of new federal guidelines that just came down the pike, appropriately enough, to try to stem the spread of COVID-19. And obviously, institutionalized older adults are clearly a high-risk population. And we know what happened in Kirkland, Washington, and that nursing home and all that. So we don't want that happening. Once that virus gets into that population, that's not good. Nothing good will come of that. But having said that, nursing homes are basically in lockdown mode now, and like the ones I go to here in Omaha are that way. You have to, the doors are locked, and you have to sign in and sign out, and visitors cannot come in at all. Medical personnel so far are still allowed to come in, at least some of them. Some are not. Like in some of our facilities, podiatrists and others are seen as kind of elective right now. But more importantly, family members, again, cannot come in, and it doesn't matter how old the person is. I've actually had in the last week 200-year-old people I know that were not allowed to be visited by their families,
Wow.
That's and I get it. I get the concept. Obviously, we don't want to spread this illness to those folks, but by the same token, they don't have the autonomy to make that choice. They are not allowed to say, I'll sign a waiver saying I'll take that risk because I really want to be with my family.
Well, that's actually a very important point, and I didn't really view it. I haven't had enough of a chance, just like everybody else. I've been so busy at my academic medical center doing this, that, or the other in preparation for COVID-19, which is all relevant. But just that question about our elders or our geriatric patients' quality of life as opposed to quantity, and I'm not saying we have an answer to it, but just that. I mean, if many people in my family live to the age of 88 or 90 with full mental faculty, so I'm not actually sure that I would, if I was in a nursing home, I would absolutely view that as a loss of autonomy and the inability to say that I actually am willing to take the risk to see my family, because at that point in time, that may be the thing that is giving you the most meaning in life. That may be the thing that's giving you that positive spirit, or that prevents our elders from that allows our elders to have a sense of wellness. I actually think that's a very, very, very interesting point, that this situation has evolved so rapidly. We just haven't had time to consider it. We just have not.
Right. I think that's absolutely right. I think that all the efforts that are being done are certainly well-meaning.
Yes.
And and as you say, this thing is just in the last week. Everyone's lives in this country and around the world have changed dramatically. So we're trying our best to stem this thing. But I think you're right. Some of those potential consequences have not been thought through because we haven't had the time to do it. Well, let me give you another example. So in the facilities, some of the facilities I'm going to, again, not only are visitors not allowed, but the social distancing rules are being applied to folks that are institutionalized. So congregate meals not allowed. So you have to eat in your room.
Wow.
Playing bridge or bingo together not allowed. So nursing homes are trying to figure out how in the world to keep people engaged socially as best they can. So they talk about like doing hallway bingo. So you have the bingo card in your room, and the nurse or the recreation therapist is out in the hallway calling off numbers, or they call them on the loudspeaker or something. So at least you can stay engaged with the game, which is good, but it's not obviously as good as being in the same room with some friends and fellow residents and staff.
Well, yeah, I agree with you completely. And as we're talking about this, because all of these things start to interrelate. So we have loneliness. We're talking about loneliness. But now as we talk about it, and you can do it multiple ways, because if we have loneliness and we have loss with lack of control. So I'm thinking about the loss not only of our geriatric patients seeing their loved ones. I'm also feeling about the loss and also likely guilt that, if you will, daughters, sons, they feel if they have made, which a number of people do, make regular daily visits to the nursing home, and that's going to, in and of itself, create some specific challenges. I mean, just as I talk about this, you got to really, 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 interesting is the wrong word, but we have to be mindful of this is a recipe for a lot of, if you will, not only sadness, but precipitants for clinical depression in a number of individuals, not just our geriatric population, even though we're focusing on that. It's just interesting how all of this spreads, and it has ripple effects that we may or may not even be fully considering, again, because of the speed of it and the need to, honestly, at times we're kind of reacting now as opposed to responding, but the need to do something immediately.
Yeah, well said. I would agree with you. I really, that's a very interesting point that I don't think I've heard articulated elsewhere. What about the guilt and sadness and the isolation on like say the children of institutionalized
Absolutely.
people? Yeah, that's a great point. That already probably feel a certain degree of guilt, perhaps, about having to make that placement in the first place. But that's a really interesting point. And obviously people are doing their best to stay connected with phone calls and,
right.
FaceTime and other, media insofar as they can. And that's, I think, the best we can do right now, but it's not the same.
Yeah, it's really interesting. And again, I'll delve a little bit into my life here. And I think many of our listeners are, depending on if they're in the same age cohort as me, mid-40s, not quite 50 or so, but, children of the 70s and 80s. But we've got our younger generation here. But I'll speak mostly to my mother and my grandmother who passed away. But my grandmother was in a nursing home, and my mother made a point to see her every single day. Mm-hmm. Until the day that she passed away. And I know for a fact that was very meaningful to her as well as to our family. She didn't take a vacation during those 2 years. She didn't do anything because she did not want to miss a day seeing her mother. Now, I know because I've been in a nursing home that she was not alone. There are many people that do that. So again, there's many, many, many far-ranging effects of this. And I would also say that my grandmother at that time was definitively demented, but she did know whether my mother was there or not. I think that's also something that needs to be said in regards to loneliness. I do believe that the last thing that left my grandmother would have been, for her, the knowledge of my mom being there, which I think stayed literally until the very, very, very end. If there's one question she would ask was, is Gloria here? That's my mom's name. Is Gloria here? That would be the one thing she would know. So I find this all very, again, loneliness, this isolation, how the ripple effects it has on the family system as a whole. I find this all exceedingly, these are just questions that we have to ask. Now, the next, we talked a bit about alone and loneliness and given our best little kind of take on it. The next thing I want to talk about, and we can expand this now because I find this very interesting, this idea of social distancing. This social distancing and what we think it's doing. We can talk about our geriatric population first, and then we can continue to expand.
Yes. Well, yeah, it is. Again, it probably is to some extent a generational thing that might be easier for younger adults to sort of deal with those consequences because they're media savvy, tech savvy, and all that sort of thing. But I think again, it is kind of a generational thing here. And I wanted, also incidentally, I wanted to kind of dovetail or jump on something you said earlier too. That there's a difference between quality and quantity too.
Mm-hmm.
I just wanted to applaud you for saying that. It's like the old saying about quality time with your children versus quantity. It really is. That's an important point. That's an important point for sure.
Okay. Well, okay. So with the social distancing, I think it has a number of effects. Just off the top of my head, I mean, obviously we have to keep a certain distance. But many people, I mean, I'm not usually one of them, but a lot of people are touchers. They touch, they hug. One of the most affectionate things that you can do is to hug somebody. Today is actually, as we're recording this, today is match day for medical students. They find out where they match. So congratulations to all the medical students that are matching across the country, as well as in my own home institution of GW. We're all very proud of you, and you all are most likely going to be practicing in an environment that nobody has seen probably in 100 years. So applaud to all the graduates as well as their families. With that being said, talking with some of my fellow colleagues, people were talking about how they miss the hugs. They miss this. They miss that. They miss actually being, not even if they're not hugging, being in close proximity or their physical presence. And I do believe that is something that is in terms of the effect, again, in terms of that connection with folks. The other thing in regards to social distancing, particularly with the guidelines, I don't know if you've had this experience. You can become very much afraid if you cough or you sneeze of being around a geriatric patient. You don't know if that's a very daunting thing because our leaders are giving us kind of very clear, even if you are not vulnerable, which honestly recent evidence, particularly with those affected by the coronavirus under the age of 55 coming out would, I think, shed some new light on that. But even if you do not think that you are vulnerable, what are you going to do to your, if you will, loved one or someone else who is a vulnerable population? I mean, what we've been hearing now is over the age of 60 or with medical comorbidities. So that is going to, what I'm seeing is that if you go outside now, if you've been in a grocery store recently, someone sneezes and you back away, or people really, it gets more attention than it ever would have before. I remember being in church and there was somebody sniffling. And we were observing social distance at that point in time. But for the first time in my life, I swear I could hear every single sniffle and cough in every single area of the church. I knew where they were. I knew where my kids were. But I knew everything. And I guarantee you I was not the only one. But another effect of that social distancing, I don't want to call it paranoia. That's a little bit of a strong word. But an increased level of vigilance, which could even get in the way of you just having, I would say, typical social graces, for lack of a better word.
Yeah, and it is certainly, vigilance, hypervigilance maybe kind of halfway between normal vigilance and paranoia, so it's kind of heading in that direction for sure. One of our local grocery stores said that they are cutting their hours, and I'm sure this is happening all over the country. They're leaving the first hour in the morning open for people over 60, after they've cleaned the place overnight and all that sort of thing. But to your point, they're actually putting up I guess like plexiglass shields between the cashiers and the patrons and such, because we're all becoming like hyper acutely aware of these factors. So let's take this back then to the nursing homes. And what if you have, well, first of all, yes, older people, all of us have that need, that touch need, and there's a science to this that I don't pretend to be an expert on, but it increases the production of oxytocin, or the release of oxytocin and so forth, which we need. People that work in nursing homes, nurses and techs particularly, have known for years, without reading evidence-based studies, that a little touch on the arm, sometimes a little massage, a little back rub in older person that's anxious, a person with maybe some cognitive problems from Alzheimer's disease that's upset because of their forgetfulness, whatever. A little touch goes a long way. And I think they're probably still going to be able to practice that. They're going to have to, and they want to. But, what about that? Well, I was going to say, what about the family member visiting? I guess it's a non-issue for right now because they're not visiting.
They're not visiting.
Right. What about, my fear, though, too, is what if, somebody does develop an illness and you're worried it is COVID-19? What if they have dementia and they won't be able probably to self-isolate because they're not going to remember to stay in their room, for example, and so forth. Incidentally, we're starting to have some of those same discussions about like inpatient psychiatric units. What if someone, a younger adult there, has a psychotic disorder, but now we're worried about COVID and all that. So and frankly, again, I know it may sound like a little bit of a tangent, but I think it really ties in. One of the treatments for people that are hospitalized with a mental health condition, one of the basic forms of treatment, in addition to the medication and the psychotherapy, is socialization. We get people out of their rooms. We kind of really insist that they do. That's part of the treatment. What if that goes away for a while? That's going to take away one of our best tools.
Absolutely. Now, we've talked about a lot of different things. We talked about if you will, some of the consequences of loneliness as we best understand it in the geriatric population. We've talked about the differences between being alone versus being lonely. And we've also started to touch base a little bit on maybe some things to think about in terms of the social distancing when dealing with the geriatric population as well as others. Let's maybe think about what we actually have out there and see, we're just going to continue talking, like how can it be of benefit? Let's maybe just start with the first question in terms of the combo of loneliness or being alone or lonely. And what about cell phones? All right, now clearly, of course, everyone's like, duh. All right, yeah, you can use cell phones and FaceTime. But is there a different way in which we can think about this or think even more creatively about how we can use this to deal with or combat loneliness?
Right, and right. And this might be a time when people get really creative, and maybe there will be new apps coming out and such that, I don't pretend to be technically, gifted in that way to come up with it, but somebody out there is, I bet. A simple to use app, a social connection app that's much easier and accessible for older adults. Is there a way to take, the monitors, big screen monitors, and turn that into, and I'm sure there is, and maybe it's already being done, but, use those as a way of doing video chats with the family.
I think that's a very good point. Here's something, and I don't have an answer to this, and I wonder, I would almost wish like this was live so our readers could chime in. I have, or not listeners as well as readers. Let's go back. I mean, I've watched, like, I don't know, I'm thinking Dick Clark New Year's Eve as an example, dating myself, or even listening to the radio. There have been times that I've been alone, but I've been either watching something or listening to the radio, but I haven't felt lonely. I've, in some way, shape, or form, felt connected to what is going on with that group of people.
Yes.
I don't know how people work that magic, how they do that. This is where we'd have to go outside of our bounds, but I know it does exist. I mean, to give you a recent example, we just did our match day virtually. And somehow I'd have to really dig through it. It wasn't the same as in person, but we still felt connected. Maybe because people were in small groups and we were panning from place to place. Maybe because we were all doing something and not just strictly talking. Maybe it was because we were all taking part in a shared story. I don't know. I don't know, but this goes back to what you say. We got to be a little. Let's go back to something that Carl Bell said. Our dear departed colleague. He gave a grand rounds I'll never forget about. He said a blending of old and new technology. How can we take what's old and worked and blend it with something new and maybe be a little bit creative with it?
Right. Yeah. Right. I think so, and I think Americans and other people around the world rise to challenges, and this is a challenging time. But it is. I would say I'm encouraged by some of the things I'm starting to see. So like neighborhood groups are starting to do volunteerism and such. And I just heard today that actually one of our local radio stations is trying to coordinate an effort of having elementary school kids write letters to institutionalized older adults, for example.
I like that.
Right? Because they especially snail mail for that generation, they love it. Getting something in the mail is like a big treat, So maybe we could mobilize folks and have campaigns like that.
I think that's actually a great idea. I mean, now I'm going to go back and again, my daughter, my oldest daughter, I still remember her saying that, you know what, Dad? I really miss school. In the time she'd get frustrated with school, but she's like, I really miss school. And she misses that socialization. She actually misses a lot of it. And interestingly enough, particularly, I won't say her generation, but maybe millennial generation, but other folks, they actually enjoy interacting with their elders. They actually, I can't speak for everyone. I'm just speaking about my daughter, but she actually enjoys it, and I actually think that that's a very interesting thing in regards to how can we be creative and keep people connected. So cell phones and things of that nature are one thing. Is there anything? Let's maybe get a little bit more. Let's get into maybe a therapy wheelhouse. Let's get into that. Let's say, and this is going into your wheelhouse, Dr. Wengel. We're treating one of our, if you will, elders. It could be outpatient or inpatient for this. Let's just take it for example, because at this point in time, many people, if you haven't already, or if you're anything like my institution, you have geared up for telehealth, whether it's Zoom or what have you, or whatever platform that you're using. You've geared up for it. All right. What might be helpful in just a broad-based therapy style, if you will, not looking for specific theory, to help our elders, our geriatric population deal with loneliness?
Well, that's a great question, I think. To me, it maybe comes down to maybe two factors. One is having some structure in one's life. Structure is really necessary, and that's why you're the second person today to tell me that their child had said that, and it kind of surprised them. I miss school, because normally children complain about school oftentimes and whatever. And, the thought of having this long extended vacation at home sounds like a great thing until you actually do it.
Right.
People are saying the same thing about work. Like, gosh, our institution, like everywhere around the country, is saying work from home if you can. But I have colleagues that are saying, can I come into work?
Yes.
Right? Because they miss that structure. And it's like, normally a week ago we might have been complaining about our job. Not at the University of Nebraska, nor at GW, I'm sure. None of us do that. But
of course not.
Right? But that structure, and part of the structure is the people you just bump into, and those little random hallway chats that you don't think much of, but just that stuff, you miss it when you don't have it. When you see an empty hallway in your office or your hospital, it's like, that seems kind of strange. So I think the structure is part of it, but I think the other piece is kind of maybe coming back to the volunteerism. One way to get outside of your own head is to do something for somebody else. And Americans are known for this, sort of helping people raise the barn together or whatever. Maybe is there a way that we can, we talked about people outside the nursing homes, for example, like school kids, writing letters. What about within the institution, even somebody with dementia? Could we find ways to give them something to do that helps somebody else, another person there? Can they help feed the birds in the aviary? Most of these nursing homes have aviaries. If you have another living being, whether it's a person or an animal that depends on you, that's a good way to kind of combat the loneliness, I think.
That's a very good way. Okay, you just put a couple of things into my head that I like. All right, first thing that I think about in structure is so very, very, very important, period. It absolutely is. I believe that if we work with our patients, regardless of their age, but in this particular case, geriatrics, but it could be anybody, if we add a certain level of structure, all right, that structure is going to allow you to get into a natural rhythm. And also, now I'll go a little bit into my wheelhouse. If done correctly, you're going to be able to maybe start to recognize maybe some cognitive distortions, maybe some things where you weren't examining the evidence, where you weren't as alone as you thought you were. And that can start to dig into the loneliness, because then you have the structure. The structure then allows you to have your day a bit more organized, so that to me, when I think about the volunteer aspect of it, I think of behavioral activation. It can be very difficult for us to break a previous routine of life, and that requires a certain level of activation energy. But if we actually force ourselves to do something different and in a different way, we can also start to realize that, hey, maybe I'm not alone, and I am around a lot of people. I just have to learn how to connect in a different way and understand what that means. And then that really gets into that altruistic. And then if you figure out how to do it, share it with somebody.
Yeah.
Do it. See one, do one, teach one. That's an old medical motto.
Yeah.
Hey, look, everyone listening, look, I don't know, and I got to start tweeting more. I don't really know that. I know a little bit about social media, but not that much. But look, my daughter is taking it upon herself. Yo, Dad, you got to learn this. All right. I'm like, okay, well, you teach it to me, which gets at another thing that I think not only do people love to, if you will, help others. I can't speak for anyone else, but a lot of people like to learn something new that's going to be of immediate impact to them now. So that is, again, regardless of whatever your theoretical framework is, that's actually, I think, that could be an interesting way to think about it. I mean, ultimately, our listeners will go yay or nay. They'll be like, Norris, Wengel, you're with it or not. But we're giving it a shot. We're giving it a shot. Now, the next question I would ask, let's go with loneliness and it getting into the level of, let's say, a clinical depression. Mm-hmm. We're going to push ourselves a little bit. Is there anything that we need to think about, I don't know, in terms of pharmacology, in regards to treating elderly patients in regards to clinical depression? Is there anything that you want to let our listeners know, just from your own experience? I'm not looking for the evidence base, but just in terms of how you might go about treating a patient with clinical depression that you think has a definitive cause related to loneliness. I mean, obviously you want to treat the cause, but is there any tips or tidbits that you might give to our audience, just based off of your own experience?
Well, again, a great question, and with the two-way, interaction between, I think, loneliness and depression, that loneliness appears to be a risk factor for depression, but depression causes people to isolate, sort of a downward spiral kind of thing. I have certainly become, I think over the years, and especially, I'm old enough to remember the advent of the SSRIs, because before that it was all tricyclics and MAO inhibitors, which were much more toxic. I think back in that era, when I trained, we were much more selective about who we would put on an antidepressant.
Okay.
Whereas now, I think, and I suspect I speak for a lot of people, that, when in doubt, I just don't know if this is depression or not, but they look kind of sad, they've sort of pulled back from other people, why not try a low dose of an SSRI, for example, or another, antidepressant of choice that's appropriate for the patient. So again, I'm not advocating for wholesale, antidepressants, all the time, but when in doubt, I think it may be reasonable to err on the side of giving somebody a trial of something relatively safe, because sometimes depression is masked in older adults. Especially older men, they don't always look sad. They may just lose interest in things, for example. Okay. So I don't know if that's quite what you're asking, but that's
no. Actually, it is what it actually is what I'm asking, and I'll tell you what I heard. First off, we have to be, again, taking a little bit of what's old and what's new. If it's loneliness, this is the predominant thing. We shouldn't necessarily be that quick to give an antidepressant. The next aspect of it is, if it isn't necessary, if you have a clinical suspicion of depression, be very mindful, because it could certainly be masked. And perhaps one of the reasons they're not doing some of the things that we said, like let's say you do the therapy approach, you help with the structure, you do the behavioral activation, you do some things, and you're still not getting where you want to be, but the patient's giving you a certain report. Maybe you want to have a high index of clinical suspicion that maybe this person is suffering from a clinical depression, and that's exacerbating the loneliness. And I like that they both can exacerbate each other. And I always say, I don't really care where the intervention happens, just so long as it happens, whichever way we can get it started. So all of those things, I think, again, some of what we said is old, some of it's new, again, but it's refreshing our toolkit and making it more relevant for where we're at right now in the midst of this COVID-19 pandemic. All right, so listen, Dr. Wengel, I want to thank you so very much. I hope our listeners really listen to this Psychcast. I think there was a lot of good and practical information here, and also different ways to think about this in terms of perspective in regards to our patients. And also, again, with you being your role in wellness at your institution, and I have a little bit of that role myself at our institution, it also hopefully will not only help us think about our patients, but it'll help us think about ourselves because we're going through this too. And many of the things that we're talking about, as I think we both illustrated, we're also going through it too. All right, you know, this is we're going through in a certain way different than what. Like, you know, if someone has heart disease, maybe you do have CHF, but everybody is dealing with social distancing and quarantine. So, you know, it really is truly an all hands on deck situation. And if we can collaborate with each other and our patients, we will just be the much better forward in terms of navigating and weathering this. My final point before I hand it back over to Dr. Wengel for last comments is that if there's any listeners out there, if you got ideas, if you got thoughts, send them to us. Send them to us. I mean, you know, we want to hear them. I mean, because again, we've gotten mail from listeners before. We got a lot of smart people out there. I say a lot of people smarter than I am. And I really, hey, that's a good principle. People always say, like, you know, you want to succeed in life, make sure you talk to hire people smarter than you are. And I always tell my residents, folks, I'm training you to be smarter than I am, because look at what we're dealing with now. So, but with that being said, please send us those ideas. Send us those ideas so that we can hear about them. All right, Dr. Wengel, the last, if you will, thoughts are yours, sir.
Well, thanks for that reframing or framing piece. I think that's really good. I feel like I've come away with some new thoughts myself from this conversation, and I agree. I would be really interested to hear what the listeners or readers have to say. I think collectively we are, you know, smart people, and we'll come up with some ideas. So I'm really looking for the positives in the pandemic.
Absolutely.
I think I'm right. So I think let's use something that we will be able to use 6 months from now, a year from now, long after this is in the rearview mirror, that will make lives better.
I think that is, again, people may not be ready for what they're saying, but we're going through a lot, and we've got to look for those positives in any crisis situations. But in this case, look for the positives in the pandemic so that we can be prepared for the next one. All right, Dr. Wengel, thank you so very much for joining us on today's Psychcast.
Thank you.
And that concludes the conversation portion of our show this week. We'll be right back with Dr. RK. Welcome back to the Psychcast by MDedge. I am Nick Andrews. It's time now for Dr. Renee Kohanski.
Thank you, Nick, as always. My late dad used to say, unforeseen events change the course of life on a dime. He was truly a resilient man. We understand resilience is one of the most adaptable characteristics we can have. But is it really? Nassim Nicholas Taleb is one of my all-time favorite authors. I highly recommend anything written by him. He says, and I quote, "Some things benefit from shock. They thrive and grow when exposed to volatility, randomness, disorder, and stressors, and love adventure, risk, and uncertainty," end quote. But there really actually is no word for this phenomenon. So he coined the term anti-fragile. So while resilience resists shock, anti-fragility actually gets better with shock. An anti-fragile system is a hardy system. So let me throw out some ideas for us to play around with. The greatest generation are the children of the lost generation, those who grew up or came of age during World War I and were born between the mid-1920s to the early to mid-1940s. This was an anti-fragile generation by necessity. Remember, anti-fragility thrives on volatility and randomness, and that was present in huge amounts. It was a time of the Great Depression, World War II, Pearl Harbor. It was quite literally do or die. And the progeny of this anti-fragile generation was the baby boomers. An enduring quality of an entity is its anti-fragility, whether it's an organism or a nation. As a nation, we are built on our anti-fragile qualities. Over time, however, we have traded some of our hardiness for comfort, not because we are wrong or bad, but because we always want more for our children. Perhaps, in taking some of the fight or difficulty out of life, we've lost something. Well, here's the good news. It's still coded in our DNA, and life will always throw something completely unexpected at us, whether it is at a macro level like 9/11 or at a microscopic level like the coronavirus. Once again, we are discovering just how hardy we are. 24 little hours brings dramatic changes in how we interact. Just like movies where people regularly smoked cigarettes seems like such an anathema to us now, movies where people reach out and hug each other on a regular basis seems almost reckless. And we're moving so fast, by the time you hear this, I'm hoping you'll be scratching your heads and wondering what the heck am I talking about with this hugging thing. We are adapting so fast, we are actually finally learning to use and not abuse technology. Psychiatry was and is exquisitely poised to launch into telemedicine. What a godsend this can be for so many people, and the adaptations we will make using artificial intelligence in conjunction and adjunction, not as an alternative to medicine. We're slowing down while we're speeding up. We are relearning how to interact with each other in meaningful ways with our technology, both new and old. We're reaching out and calling each other and conversing with each other, not at each other. History will show us what this dot in time will mean. I believe not only will we flatten this curve, but ultimately we will reduce the area under the curve, simultaneously slow things down while things are speeding up to reclaim some of our humanity. But there are peaks and valleys, and we will have to take a wider angle view. I'm Dr. Renee Kohanski for the MDedge Psychcast.
And that concludes episode 110 of the Psychcast by MDedge. Let's get to this week's credits. The Psychcast is produced and hosted by the editor-in-chief of MDedge Psychiatry, Dr. Lorenzo Norris. The Psychcast is produced by editors Gina Henderson and Jeff Bauer. All MDedge podcasts are produced by the editor-in-chief of Medscape and MDedge, Dr. Ivan Aransky, as well as MDedge executive editors Kathy Skarbeck and Mary Ellen Schneider. The multimedia editor, Terry Rudd. Social media is produced by Kyla Clark. The show notes were authored by Dr. Jacqueline Posada. I'm your audio engineer, audio editor, and the host of MDedge Podcasts, Nick Andrews. You're listening to the Psychcast.